Welcome to the Next Level Human podcast. As a human, you have a job to do. In fact, you have 4 jobs: to earn and manage money, to attain and maintain health and fitness, to build and sustain personal relationships, to find meaning and make a difference. None of these jobs are taught in school, and that is what this podcast is designed to do: to educate us all on living our most fulfilled lives through the mastery of these 4 jobs. I'm your host, Dr. Jade Teta, and I believe we are here living this life for 3 reasons and 3 reasons only: to learn, to teach, and to love. In this podcast, I will be learning, teaching, and loving right along with you. I'm grateful to have your company. Here's to our next level. What's going on, everybody? Welcome to today's show. I have a special guest today, an expert in hormone replacement therapy. The good news is that most of you are always hearing me talk about hormone replacement therapy for women. And in case you didn't know, I am not a woman. So I have an expert who is also a woman on here and been doing this work for a very long time. Dr. Leita Harris is with us today. Thank you so much, Dr. Leita, for being here. Let's start with sort of your background and how you got into this work in hormone replacement. I know you're a gynecologist and this is sort of your world, but when did you start sort of really getting deep into, HRT for women?
Okay, great. Well, thank you very much, first of all, for just having me here to share with your audience. I'm very excited about being able to just pour into the lives of these women that are listening, and of course, maybe some men as well. So I've been practicing medicine for 32 years now. I left the full scope OBGYN with deliveries and surgeries and everything back in 2005, actually. So I wanted to pull away from, I guess, conventional looking at things from a standpoint of doing a lot of knee-jerk prescribing and things like that. Just when I kind of took a journey towards looking at more natural ways of helping women get better, have lives of wellness as opposed to just prescribing medication. So I kind of took a little hiatus. I did start teaching, and then I went into really learning about bioidentical hormones probably back in around 2007 or so. Actually, a compounding pharmacist who helped me initially. And I really realized after a while that what we learned in conventional medicine and what we were doing in conventional medicine, I almost felt guilty. I felt like we were doing a disservice as I dug deeper and did my own just learning and doing different conferences and seminars and things like that, really learning about hormones and the benefits of them. And so what I decided to do after a while was just break away from the whole organized structure of medicine. And I launched out my own practice 7 years ago. It's been great. It's been fantastic. I love what I say is partnering with my patients to help them in their wellness journey. I tell them that we're working together to help you to be the best you can, feel the best that you can, live the best that you can. And I love being able to give options. I love giving them ways of finding out how and what they can use to address the various concerns that they have. I'm big on telling people you do not need to suffer. I think too many people are needlessly suffering because they don't have the right information. They've been misinformed or uninformed, and they've been scared. There've been a fear that's been put into them, and actually from physicians and other providers. And I think there's been a tremendous amount of a disservice that's been done to people, and particularly women. And so that's why I'm very, very passionate, as you probably can tell, about giving people options and helping them to just get on hormones if they're qualified, and just live lives that's going to help them feel a whole lot better than what they currently are. So,
well, we're certainly grateful that you're doing this work, because obviously, as you and I know, it's needed. And those of you listening, Dr. Leita is in private practice, so she is available to be seen. She's in out of California, but she also works with Evolve, who is a sponsor of the podcast. And one of the reasons that I am talking to her, because I told them I want your best, person on HRT to come on and educate us. And so that is why she is here. And you know what I want to do to start, if it's okay with you? You mentioned this idea of, fear, and this whole idea of fear around hormones. This has sort of been one of these things that I'm sure I know me, we're always battling against this when we have someone come to us and we say, hormone replacement therapy may be a powerful option for you. And then we get right after that, oftentimes, a pushback. So I'm curious, is this all coming from, mainly the Women's Health Initiative study? Is that mainly what it is? Are we still dealing with the consequences of that information? Or where do you think the fear is really coming from here? I know people think there's risks for certain things, and I'm wondering how you educate people to get them to sort of understand what has happened here and why they may not need to be afraid.
Absolutely. And you're right. I think that the Women's Health Initiative, which is now 20 years old, did a tremendous disservice to the overall health and wellness of women. And I think people like us who are a little bit more progressive in looking at things and really analyzing realized that it just really did a disservice, if I can put it that way. And unfortunately, too many doctors and other medical providers are still leaning to old and invalid statistics that came from the Women's Health Initiative. I mean, it freaked everybody out. I remember it very well back in 2002, and where all of a sudden I had to start, trying to convince my patients like, oh, okay, hey, let's look at this a little bit more closely. The problem is that, several things, it was the statistics in it. It wasn't something that was really valid. We're talking about like a very small number of people that supposedly had increased risk. We were looking at a study that was on synthetic estrogen combined with synthetic progesterone. And I tell them, even in the group that was only on a synthetic estrogen, they did not have any increased risk of cancer. I really want to focus, though, on what has recently come out. I'm very happy that back in 2017 and even this year in 2022, the North American Menopause Society has actually put out another statement that is almost, if people look at that and if other physicians look at it, they realize, okay, the risk of breast cancer related to hormone therapy use is low, rare occurrence, and there's other confounding factors. It's almost the same as someone who's, more alcohol or obese. That is a kind of comparison with the risk, unfortunately. And people are looking at this and saying, oh, okay, hormones cause cancer. And it just simply does not. In fact, there's a reduction in a lot of the different cancers. There's a reduction in cardiovascular problems, which, of course, more women are going to have death from cardiovascular disease and coronary artery disease and that type of thing at postmenopausally more than cancer. Everybody freaks out about cancer, but they're not looking at the heart. Hormones are, of course, going to be beneficial for heart health. It's going to be beneficial for our brain health. It's going to be beneficial for our bones, for our bladder, for the vagina. All of these things are important, not only for overall health, but also, because of just looking at what really are the cancer risks that's there. So I'm really happy that when I looked at some of the key points in the new statement, they really did say that it's less, that women can consider a hormone replacement and not necessarily look at this as something that's a high risk. And even with women that have had a history of breast cancer, this was very profound when I took a look at it. So yes, the fear is still there, unfortunately. It is coming from doctors. It's coming from medical providers who are not maybe aware or not fully informed. But I also believe that the media, I look at, things that maybe articles that come out that people search Google. Okay. We know that, right? Yeah. And when they see and they don't understand that they're mumble jumbling all of the different, estrogen therapy, menopause hormone therapy, ERT, MHTET. People, the layperson doesn't understand this. And when they look at it, superficially, they get fearful. And again, it's a lot of misinformation, lack of information. So some of it's coming from media, from different things that they're maybe Googling, as well as from other medical providers that just don't have the right information, unfortunately.
Yeah, there's a lot there. So I'm going to just repeat back. Thanks so much for that. And make sure I get this right, because I just want to, all of you are listening. If you're listening to what Dr. Leita's saying, she's essentially saying this WHI study, Women's Health Initiative, which is a big study. The first sort of results came back in 2002, was showing some things that were scary for a lot of physicians and for a lot of women. And also the media sort of jumped on that, showing increased risks of certain cancers and increased risk of other things related to hormones. If you're listening to what Dr. Leita is saying, she also is pointing out that, first of all, this was equine estrogen, so not bioidentical estrogen. It was also progestins, which are not like the natural progesterone. But even if I'm hearing you correctly, and I've looked at this data as well, even in that case, with the new data coming out, and by the way, those of you who are listening, one of the things Dr. Leita was pointing us to is when you have these large cohort population studies where they're looking at one thing, there's a lot of confounding variables. And she mentioned that. Things like, are these people alcoholic? Are they obese? How all of this is impacting us. And the new information, it sounds like you're saying, Dr. Leita, is actually showing that not only were we wrong to be afraid of the WIH, sort of research, that actually that there was some decreased risk and or no risk at all when they start looking at the data again over the long run. And this is with, synthetic estrogens and progestins. Now, we have not yet talked about bioidentical hormones. And so maybe we want to kind of get into that a little bit because, for example, I know that a lot of people point to the progestins as being, or at least they did, as being the big problem here. And I am aware of several lines of research, several studies showing that when you use bioidentical progesterone, the risk of breast cancer seems to go away and may actually be improved upon with bioidentical progesterone. So am I correct in that? And how should we be thinking about this? Do you still use some of the synthetic hormones, or are you convinced that only the bioidentical hormones are appropriate? Because I know a lot of people would say, well, my doctor is giving me the synthetic hormones. We now know that the risk of those is probably not that great. You may even be getting some protection from those. But what do we know about these bioidentical hormones in comparison to sort of the standard traditional HRT? Are we getting better outcomes?
Sure. And just to define, so people can and fully understand, people shouldn't get like freaking out when they hear the term, bioidentical hormone, because you will see in Google like, oh, okay, it's not FDA approved and it's not this and it's not that, it's not regulated, etc. Bioidentical hormones is basically just hormones that chemically, structurally, they're exactly the same as what is produced in the body. So bioidentical, identical chemically and structurally to what is normally found in the body. So estradiol is a bioidentical hormone. Are there versions of bioidentical hormone that is approved, through the FDA? Yes, there are. There's bioidentical estradiol patches, there's estrogel, there's oral. Okay. Now, personally, I do not do synthetic hormones, and I haven't done that for decades. I just don't do synthetic hormones. So, and I understand, the whole thing of that, hey, your insurance might cover one version of it and not another version of it. But what we have to understand is that everything that you ingest has to be metabolized. Okay. So those metabolites can affect your body in ways that, sometimes we don't fully understand, or it can be a negative impact on our body. So you're absolutely right. Progesterone, which is like a micronized progesterone, is exactly the same as what is chemically in our body. Now, sometimes what I do to really emphasize for women is that a pregnant woman can use a progesterone, okay? But it's contraindicated for them to use a synthetic progestin. So when you think about safety, absolutely, a natural micronized progesterone is going to be, of course, safer, better. And yes, you're right. There has been some observational studies showing that it could even be breast protective. Natural bioidentical progesterone is something that behaves differently in our body. It's totally opposite to synthetic progestin. So it's a natural diuretic. It helps with our mood and our, just stability. Oral micronized progesterone interacts with the GABA receptors in our brain to help us sleep and to calm us. So, when you think about something that behaves a certain way versus a synthetic version of it, absolutely, it's going to be better. It's going to be better for us. So bioidentical, again, just means that the structure is the same as what your body naturally produces. Just looking at things from a theoretical standpoint, you want something that's going to be more natural so that your body recognizes it. And as it is metabolized, those metabolites, the end products, will affect us in a way that's totally opposite or different potentially than what a synthetic metabolite can do. So I was very happy, as you shared, that yes, natural micronized progesterone can be actually protective. It behaves differently. It's going to be different as far as what it's going to do combined with, say, a natural bioidentical estrogen in our system versus a synthetic progestin. Very, very different.
Yeah, that's great to know. So let's go through just clinically how you work with patients then. So, obviously, when we look at this, there's, the perimenopausal state, which can last a pretty long time, up to 10 years. This is where, essentially progesterone levels are beginning to drop and estrogen levels can be very volatile through this process. And this is oftentimes where a lot of the symptoms come from. And then, of course, there's menopause, which technically for you and I in the medical field, menopause is basically a single point in time, right? We usually define it as, being without menses for a year or a particular number on your FSH. But there is a distinct sort of hormone, sort of reality there when someone finishes perimenopause, where now rather than estrogen being high and low at times, it typically is low. So I like to think of perimenopause as sort of like this fluctuating estrogen. Sometimes it's high, sometimes it's low, with lowering progesterone. And then menopause, this post-menopausal period being sort of low estrogen and progesterone. So how do you deal with this with someone in perimenopause? Are we talking about progesterone therapy by itself to sort of balance out this estrogen? And then is there any difference as we move into menopause? I'm just curious how you begin to sort of look at this.
Yeah, sure. Yeah. So what I usually explain, to our women, and you're right, I mean, this can last for 10 or more years. I mean, when you start kind of looking at the fact that, yes, what I tell my patients is that the hormone that usually drops or declines first is progesterone. Okay. Because, progesterone, as you know, is, produced after ovulation. And so normally you have estrogen and it's going to be produced during the cycle. But then with ovulation, that's where progesterone comes into the game. Okay. So I tell people, just think about how you feel from ovulation all the way up until your cycle. That phase, that luteal phase, when there's progesterone being produced, that is going to be something that's going to be fairly consistent during most of your reproductive life. However, when you start getting into that perimenopausal phase, where you may either skip ovulation altogether, still producing estrogen, and like you say, up and down, but there may be less progesterone produced or no progesterone because ovulation totally is not there, then you have a completely different balance with the hormones, where estrogen may be a little bit more dominant because of high levels of estrogen or too low of a level of progesterone. So most of the times, and then symptom wise, oh my gosh, I tell them that this is the roller coaster years, right? Mm-hmm. So you're kind of like, you may have your period. It might be too short. It might be too long. You may skip it. You may have 2 in a month. You may be heavy, you may be light, and then it becomes more and more spaced out until it stops. So during the perimenopausal phase, progesterone is actually the primary thing that I support my patients with, because we don't know that estrogen still may be produced. So progesterone is the one that I usually use during perimenopause. And then but I do let them know, I said, this is going to be for now. But this is a journey, remember? This is a journey. So progesterone may be what's needed now, and I will kind of throw in sometimes testosterone, sometimes DHEA. But then as time goes by and the ovary produces less and less estrogen, now we have to add estrogen to your regimen, to your protocol, so that now you have both of those hormones working together again to support you. And it's crazy because, I tell them, you can have like menopausal symptoms, the hot flashes and can't sleep and mood changes and weight changes and all of that, and still have your periods, So it's like one of these, like, oh my gosh, times of your life where you're feeling like you're in menopause, but you're still having periods. So supporting them, as you said, is like with the progesterone initially. And then, of course, eventually estrogen is something that is going to be added as those levels decline as well.
Let me interrupt the show just for a few minutes because I want to tell you about one of our sponsors, Evolve Telemed. One of the questions I get all of the time, one of the services that you are asking me for constantly is hormone replacement therapy. Women going through menopause, women going through perimenopause, women in postmenopause, women under stressful situations who are dealing with low sex hormone levels, estrogen and progesterone, are constantly asking me about progesterone therapy or estrogen and progesterone therapy. And men, same thing, constantly asking me about testosterone replacement therapy. Plenty of you, many of you, always asking, Jade, can you prescribe me hormones? I need testosterone if you're a man, or I need estrogen and progesterone or testosterone if you're a woman. And I always have to say that I am no longer seeing patients in this way because my educational duties are keeping me so busy. And this is where Evolve Telemed comes in. I have been looking for a company that does bioidentical hormone replacement therapy, and that is critically important. If you're going to be doing HRT or TRT, HRT being hormone replacement therapy for women, TRT being testosterone replacement therapy for men. If you are going to do these therapies, you want the bioidentical hormones. You want the hormones that your body makes naturally, that your body can recognize, that is no different from the hormones your body would make if you were making adequate levels. Bioidentical hormone replacement therapy does just this. And Evolve Telemed is a company that I am now using for my own testosterone replacement needs, and have been super impressed with the way that they have structured their business model. And so I am now bringing this service to you through my partnership with Evolve Telemed. Essentially, the way this works is you go online, you make an appointment with Evolve. Evolve gets a doctor with you on a Zoom call. They go through your whole case. They go through your blood labs. They then prescribe your hormones directly to you, and you can get those hormones wherever you are. You do not have to go to a clinic near you. All you need is to have an internet access point, and you can meet with an expert in bioidentical hormone replacement therapy and get those prescriptions. Now you can see why this is so powerful, can't you? Because this is something that so many of us need and can benefit from for our aging needs, our sexual health needs. These things have profound impact on mood, hair, skin, erections, libido, you name it. These things do everything for our metabolic health and vitality. So I am incredibly excited to bring Evolve Telemed to you. Now, the link that you go to is drjade.com/hormones. drjade.com/hormones. This will bring you to the Evolve Telemed portal. If you use the code NEXTLEVEL, you will get a discount on checkout for your first patient visit. I'm very excited to be able to bring this to you, and I hope you will use Evolve Telemed. I know you're going to find it extremely powerful to move your hormone needs over to them. Check them out, Evolve Telemed. Use the link drjade.com/hormones. drjade.com/hormones for Evolve telemed. And let's get back to the show.
Yeah, I love the way you're speaking of this, because if all of you listening right now are paying attention to Dr. Leita, what she's essentially saying is there's a very sort of deep understanding of what is happening hormonally. So in this perimenopausal state, notice how she's not using estrogen, but primarily progesterone, and the way she explained that to us about how progesterone is what's really needed to be supported here. And so then you begin to move into the menopausal state. And, at what point do you perhaps start transitioning over to maybe an estrogen plus a progesterone? And then I'm also interested in whenever you use maybe estrogen alone or a testosterone. And just for the listeners, so you understand, normally when we're in clinic doing this, menopause, normally we can run a test called FSH. Usually when it's above 30, we will define that as sort of menopause. I don't know if that's how you define it as well, Leita. And also, we can just basically define it as you haven't had menses within, a year. So we look at both of these markers, and I'm wondering how if you use these markers, or if you're just going on symptoms when you start to go, okay, maybe I'm going to start using, some estrogen therapy as well. And I'm just curious on how you work your clinical practice on when it's estrogen plus progesterone, when you might want to do estrogen alone, when you might want to use estrogen vaginally, and when you might want to use testosterone. Just curious on all those levels.
Yeah. So basically, given a person who's still like very much having their cycles, I explained to them, I'm not going to give you a bunch of, estrogen because, that's going to make your bleeding worse. Potentially, and you may not necessarily be very, very deficient at that point. So I do serum levels. I do check their blood levels, and I do let them know, and I show them. I say, okay, hey, look at your estrogen is fine right now. So, this is where you are, but just knowing what you're sharing with me, this is where the progesterone comes in. We know what's going on with your body because of what you're sharing with me. Now, the transition may happen where okay, they're kind of skipping like long stretches. They may not get to a full year, but when they start really skipping, like they're using a progesterone, they're not having any cycle. Maybe some of those vasomotor, which is like the hot flashes and sweats and things like that, are worsening, or they may start noticing other estrogen deficiency symptoms such as vaginal dryness and things like that. Then I might kind of check again and say, okay, it looks like it may be time for us to at least start. But if they haven't gone for a whole year, I always tell them at any point in time, your own ovarian production of hormones might increase. Okay, remember the perimenopause is on again, off again. So even though we're supporting now with a little bit of estrogen, there may come a point where your ovary, like you may have a surge and you may produce estrogen on your own. So you have to be aware of that. And if that happens, you may notice like, oh, here comes a period again. Here comes a cycle. And yes, I look at FSH as well. But I also let someone know that if you're perimenopausal, if your estrogen is low for a long time, your FSH may be high. But again, if you have not gone through that whole time where there's no more follicles, you can all of a sudden, boom, have a surge. That estrogen goes up and that FSH comes right back down. Because now you're producing estrogen. You may have that moment and then your FSH comes down and then it comes down. And here we go back again to that long stretch without anything. So I do estrogen, at some point in time, where a lot of times is when they may be, the symptoms may be increasing. The progesterone is not holding everything as well. They may be skipping their cycles. Now it's time to add on a little, but I always give them a little caveat. We're going to monitor and see how you're doing with your own potential body's surge of estrogen. Testosterone, I truly, truly believe in testosterone. Okay. I think it's actually amazing. Sometimes I see women's testosterone decline, even like in their 20s and 30s, they have low testosterone. Some of them, I know some of it may be genetic. Some of it may be, environmental things. Some of it may be they were on birth control pills for so long, and it may have suppressed and knocked things off as far as their whole hormonal balance. So when I see low testosterone and a woman is complaining of, low libido, low energy, have no muscle tone, muscle strength. When they're exercising, they just don't feel like they're getting what they need. I go ahead and add testosterone to their regimen. And again, I do use blood levels to see where they are. And I tell them, hey, let's just kind of try to get you into a better range with the testosterone. I look at DHEA as well, from the adrenal glands. That's another androgen, another precursor to testosterone and estrogen that could be also replaced if that's low. So that will help to support, again, the whole hormonal structure. So that way everything is improved, over time. So,
and is your primary indication for testosterone in your clinical experience? Do you feel like testosterone or estrogen is more enhancing libido? Is it both? Is it more the testosterone for women? And when do you look at that?
Yeah, I think it's both. I do believe that they work, in conjunction with one another because, and it does vary person to person. I mean, sometimes I'm going to tell you very honestly, I've had patients that have fantastic testosterone level and they're telling me I have no sex drive, it's not an absolute, and so, and I also say libido is multifactorial, it's not just, testosterone level. It's not just estrogen level. There's other factors. It's relationship issues. It's, how someone feels about themselves. Okay. It's also physical sometimes in nature. So of course, if a woman has gotten to the point of discomfort, physical things that are happening when they are sexually intimate, and it's a negative experience, then of course, they can have decreased drive because it's connected with a negative experience. So if we help that negative experience, let it be something better, then that can also help. And it may not necessarily be anything related to testosterone level. You see?
Yeah.
So
100%.
Lots
I agree
of
with
factors.
that.
Yeah.
Yeah, a lot of factors there actually, and let me ask you this just really quickly because I know, typically I think about it now, and I just want to see how you think about it. We usually think about giving progesterone orally. We no longer really think about, at least from my perspective, giving estrogen that way. It's usually done in creams or patches and things like that due to the clotting issues and some issues around that. So it's just something for you listeners to be aware of. Most practitioners who are up on this are doing progesterone orally, but not giving estrogen orally, although it can be done vaginally, but it's usually creams, patches, and things like that. You also mentioned to me that you do use pellets on occasion, and I'm assuming that's for testosterone. And have you seen that, or do you use those for estrogen as well? I'm not aware of the estrogen pellets, but maybe you want to talk a little bit about that because I know women are probably just like, okay, my doctor wants me on pellets versus creams versus patches, and which ones you like.
Sure. Well, okay. So, I agree 100% with you with regards to the oral estrogen. And this is what I counsel my patients with. I just say, I don't do oral estrogen because of the fact that it has to be metabolized in the liver and the potential for, thrombogenic with clot forming and things like that, because oral does not behave the same as transdermal, which is, like you said, patches and creams and things like that, nor with the pellets. So the pellets also bypass the liver metabolism as well. It goes directly into the bloodstream. So yes, my preference is exactly how you said. I'll use a transdermal form of estrogen. I'll use an oral form of progesterone for the reasons that we spoke of already. But then with regards to testosterone, of course, there's no oral version of testosterone for a woman. Some women, can use injections if they're comfortable doing that on their own. But I like to do pellets. I have hundreds of patients that use pellets, and that's their choice. And you can do estrogen and testosterone pellets. Okay. But for a woman, we still give them oral progesterone. So the pellets, of course, are placed subcutaneously, and they're compressed. It's a compressed hormone that's in a pellet that is a slow release. So as the cardiac, function increases, like exercise, physical activity, etc., it slowly releases it directly into the bloodstream. So what you can get essentially is a nice sustained release over a long period of time. And long meaning for some women it's 3 months, for some it's 4 months, for some it's 5 months. Okay. I also do male hormone pellets as well. I do testosterone pellets for my male patients as well. So I'm a gynecologist, but I tell them, hey, if you don't mind seeing your gynecologist, I can take care of you as well. But yes, you can do estradiol as well as testosterone pellets. And it's a slow release that's over, like I said, 3, 4, 5 months. It just depends on a woman's or in a man's metabolism, how quickly it's released, how quickly they use it. And it gives them a nice, steady level of release of the hormones into the bloodstream.
That's great. That's great to know. And, we would be remiss, you and I, in this conversation if we didn't cover something that comes up a ton. And maybe we can sort of have this discussion and end here. But obviously, people, when they're thinking about hormone replacement therapy, they tend to think, oh, I'm going to lose weight, and we kind of know in the research that, and I'll just give you my reading of it, and then we could talk clinically what we've each seen. My reading of the research of course, there's not as much of the bioidentical hormone research, is that typically these do not cause weight loss in women. Some research suggests that it may actually slightly increase weight. However, what we do see in the research pretty clearly is that it does seem to have a pretty profound effect on mid-fat, belly fat. It seems to reduce belly fat in women. I know this is confusing for some women. So they're like, well, I'm not losing weight, but I'm actually losing belly fat. Part of that might be the fact that it's helping maintain muscle mass. Remember, estrogen is like a weak testosterone in a sense, and its ability to help maintain muscle. But it does seem in the research that it does help to maintain that beautiful hourglass shape that women tend to lose as they move into menopause. Now, clinically, we see things a little differently. And of course, I'm doing a lot of lifestyle medicine. So I've always seen it be pretty advantageous for both weight loss and body shape changes. Now, of course, I'm using diet and exercise along with the hormone replacement therapy. But I'm curious from your clinical experience, what you see. Are the people who are just doing HRT and no diet and exercise seeing any results, or does it have to come along with diet and exercise? Are you seeing this reduction in belly fat? Give us a little bit about your clinical experience with the weight loss ability of these therapies. Sure.
And I'm so glad you asked that question. And I'm so glad that you shared your clinical experience as well, because you are so right. We do know that, of course, as women start going from that perimenopause into menopause, like all of a sudden this midriff comes on, right? Out of nowhere. They're doing everything same as far as their physical activity, their eating habits, et cetera. But here this comes. So we know that, of course, there is some change in metabolism, the change in the hormones that's going to cause that. So yes, so we do know that, helping to improve the estrogen, the hormone, why don't you say hormonal balance, is going to be important. But I also share with them, we're looking at everything. So I'm looking at your thyroid function. We know, looking at your stress level, what your cortisol may be, contributing to this. What is your insulin resistance potentially being a factor? So there's so many things that happen around the same time. So you're right. There's many things that can happen. And I tell my patients all the time, it's not just the hormones alone. It's not about me just giving you hormones and all of a sudden everything is going to get better. No, you do have to have lifestyle, factors in there to make sure that you're looking at everything. So you're right. I do have sometimes, if a patient is not really diligent with making sure that they're keeping the things healthy with the whole package, that they can start noticing increase with their weight when they go on, you see? And so it's kind of, whoa, where is this coming from? I said, well, you got to work these hormones. You can't just use hormones and just sit still. You have to do things to help it work in your body to get to the tissues where it's working, help with your metabolism, et cetera. So, it's not just fix the hormones and sit around and do everything badly and think that that's going to be the quick fix. It doesn't work that way. So you're right. It does require everything. It requires a full scope of looking at everything if you really want to make a full difference. But we do know that, yes, the hormones changes. Sometimes alone can be one of the things, but there's other factors to keep in mind that have to be, part of the protocol, if I can put it that way. So.
Yeah. And one thing you brought up, which I think is a critical thing that people should understand, is I also have seen that pretty clearly in my clinical practice of a lot of times people will blame when they think hormones, they'll tend to think estrogen, progesterone, testosterone.
Mm-hmm.
And if you listen to what Dr. Leita said, she's actually saying, hey, wait a second, there are other hormones that are perhaps more important here, insulin, cortisol, these other hormones that are sort of playing a role here. And one thing that my listeners at least know, Dr. Leita, or they should, is I oftentimes talk about the idea that whenever you try to speed up metabolism, which hormones will tend to do, they will speed metabolic rate. There is a certain subset of individuals who will, in response to that, begin to overeat. You see this with exercise. You see this with cold exposure. You see this with hormone replacement therapies and those kinds of things. We also know that fluctuations in estrogen and progesterone do have a role in thyroid. And so it's really interesting what Dr. Leita is pointing out to us here. If you are seeing changes in weight, perhaps going up, you want to look at, what happened with my thyroid function? What happened? What's going on with my eating? And so this is one of these things that will help diet and exercise and lifestyle changes make a bigger difference, but they do not seem to work, at least in my clinical experience. And Dr. Leita seems to be saying the same thing, in isolation. You're still going to need to be able to do the things that we know are necessary. It just might come a little bit easier once the hormones are on, and having a doc like Dr. Leita to look at all these other things, what's going on with cortisol, what's going on with thyroid function in particular, can be incredibly helpful. I am so appreciative of your, sort of background here and your clinical experience. It's always really nice to talk to a woman. Obviously, I've never had a menstrual cycle. I'm never going to go through menopause. So I think it's really nice for me, despite the fact that I work with women mostly, it's really nice to have a female clinician come on and essentially speak to this stuff. I think it just brings better credibility and is more important in these discussions to have a woman in these discussions. Is there anything else that you would like to leave us with that you feel like, you know what, Jade, we didn't mention this or we didn't cover this, or any final thoughts that you might have?
Well, I mean, and I appreciate, again, you having me come on and speak. This is something that not only am I helping my patients with, but, hey, I'm 61 years old. I started my stuff when I was mid-40s, and I am on my hormones. I'm on a bunch of supplements. I'm doing all kinds of things to support my body. So I'm not just talking about it, I'm walking, I'm doing it. And so that just lends itself to just the importance of what I see as the benefits. I mean, I have patients that ask me all the time, how long do I need to stay on this? And what I tell them, I say, well, how long do you want to feel good? How long do you want to feel good? I have patients that are well into their 80s. I mean, I think the most senior patient I have is 86 years old. And she uses pellets. She still gets her pellets every 6 months. I have several like in their 70s and things like that. So again, we're talking about longevity. There's no magic cutoff point. There's no such thing as like, I got to stop my hormones at 65. Why? Why? Why is that? So what do I do now? Do I just go in a corner and shrivel up and die and age, So it's not about just looking at some arbitrary number to stop. Hey, if you're healthy, if you're feeling good, if there's no contraindications, by all means, hormones can be used, for the rest of your life. And so I think that's important for people to understand as well. It's about longevity. And, hey, if there's nothing else that would warrant you stopping it for whatever reason, by all means, hey, we can use hormones as long as we want to just keep on feeling good. And for some vanity as well, looking good, right?
Yeah, 100%. And if you don't mind me saying, Dr. Leita, I mean, what a testimony you are to these therapies. I mean, you're absolutely beautiful. I can't believe you're 61. I cannot believe you're 61. Like, that kind of blew me away. And I'm sure you get that a lot. And these hormones do a lot in that realm, right? They're great for skin. They're great for the brain. They're great for a lot of things. So
absolutely,
it's kind of cool to have that testimony. If I'm sure your patients are blown away with that. Like, oh my God, you're 61. That's nuts. Thank you so much for being here. By the way, everyone. So, Dr. Leita is available through Evolve. That's how we got connected. Evolve is a a sponsor of this particular podcast, and she is also in private practice. If they want to keep up with you, where can they get in touch with you besides Evolve? Are you on social medias or anything like that, or active anywhere online?
Sure. Yeah. No, my website is nurturingyou.com. So my private practice is Nurturing You Women's Health and Wellness. I'm in Southern California. I do telemedicine visits as well. But my website is nurturingyou.com. So nurturingyou.com. I am on social media as well, as Dr. Leita. That's my Instagram, is DrLeita. And of course, we also do Nurturing You, also have a Facebook page as well. So of course, if you want to find out more information, visit our website. I have a lot of information there. And of course, social media, we do our postings as well. So thank you.
Yeah, well, so everyone, you all have now a new hormone expert who's been doing this for a very long time. She's also a patient. She can probably give you a ton of good information here. Dr. Leita, I am so appreciative of you. Thank you so much for being here. I'm going to go ahead and stop the record, but if you don't mind, hang on just for a minute because I want to make sure this gets all uploaded. And thanks so much, everyone, for being on, and we'll see you at the next show.